people, but there's people I don't even know who these names are, and I apologize if I don't know who you are. So there's an area code 210-249-4401. There's a 215. Is that you, Crawford? I hope, in Philadelphia. But they're unidentified. But Crawford's in a different area, so I don't know who the other person is. And then there's a David Wampler and a Donald Keene. Can you guys identify yourselves and tell me who you are? And there's some others there as well. Jay Aguilera.
This is Donald Keene. I'm the Joint Base San Antonio Medical Director and one of the program EMS Fellowship Program Directors with San Antonio.
Okay.
George Aguilera. I'm interning with Dr. Augustine.
Okay, got it. Okay.
Kevin Wampler. I'm the Director of Clinical Research for San Antonio Fire Department.
Okay, got it. So we got a lot of San Antonio contingent there. Okay, got it. All right, there's
a
a lot
of Crawford up here.
Okay, I got it, Crawford. Who's the other 215? Do you have an idea?
No clue.
Okay, got it. Well, this is interesting. Then I've got it looks like an NGA SAM1. I don't know what that is, but all that. So has anybody in particular got a time constraint? Usually it's Sandy Schneider has to do something at 11. Anybody else? Okay, if not, I'm going to move on and go through Michael Sayer. Are you there? I'm going to go there. Let me just give you a quick overview of what we're going to do today. Here. Yeah, good. Thanks, Mike. We're going to put you on first, so stand on there. We've got some visitors from overseas, including Paul Bailey. It's almost midnight where he is in Perth, Australia. He's got to give a report from the Eagles Down Under, or as I call it, I wonder what's gone asunder down under or not, as you'll hear. And then also we've got Pierre from Carly from Paris on the line and a bunch of others. So I want to try to get to all. David Radcliffe from Manchester, UK is here with us. So I'm going to try to give them some preference, but Mike's got to get off for another call. So I'm going to give him the first priority on all this thing here today. And a couple of things I will go over. We are going to talk today a little bit about the issues of antibodies and what they really mean. We've heard that before, but I think we want to even drill down a little bit more and get some opinions out there. And there are different initiatives going on, as you've heard before, and I'll try to address those. Then, as I heard, we're going to try to get some reports for what's happening down under, both from New Zealand, Australia, and Eagles, and we got a report from one of them reporting back. They, unfortunately, of course, it's usually 2 or 3 o'clock in the morning for them when we're doing this. So it's really privileged to have Paul Bailey on the line from us. We'll talk a little bit about serum harvesting. It's been a thing going on in Europe for a little while, and we are beginning to do it. There are some interesting anecdotes already happening. And then we've already talked a little bit about how we've been overcome by the surveys, but we'll still have some reports from Jim and Mike Levy probably. And then we do want to get into an interesting discussion later, probably after we've heard from our overseas folks, is about this whole issue about the evolving strategies. I call it plotting against the rotten clotting we've gotten. And that's talking about the hypercoagulable states we're beginning to identify and how to handle that and what we're thinking about it recently. And then talk about why some cities are seeing more cardiac arrest than others. With that, I think I'm going to go ahead and launch in so we can get you off the line as soon as we can, Mike. Thanks for your patience with us this morning. And so if you don't know, it's Michael Sayer, Medical Director for Seattle Medic One, the Seattle EMS system, and paramedics for the fire department. Mike, go ahead.
Yeah, I don't have any slides or anything, Paul. I just thought that I would briefly just talk about a work that we're doing with the Fred Hutch Cancer Research Center and the UW virology folks around some of the serological testing of our teams. As everybody's aware, there's a lot of interest in this question of really a couple of questions. So one is, what is the role of antibody testing? And then number two, a question that the immunologists have is, how come some people get really ill and other ones don't? And are there any predictors of that, and differences in kind of the immune response that may be available information in some future state that could help clinicians? So the proposal is, and we started this already earlier this week, is to take essentially two groups of first responders. So group one is those who have tested positive, and we have a reasonable sized cohort of those people, as well as other hospital employees who have tested positive at the Seattle Cancer Care Alliance Hospital, as well as the Fred Hutch Cancer Research Center. And those people will get blood drawn when they volunteer, and then repeat blood draws at days 30, 60, and 90. So they have 4 different serological blood draws. On the first blood draw, they get an antibody test that the Fred Hutch researchers developed. So they can't know the answer to that. It's not CLIA approved. Although yesterday we learned from the University of Washington virology team that they're going to bring online the Abbott IgG antibody test probably by the end of next week. And Abbott announced that yesterday, and Abbott is releasing 1 million test kits for this platform next week, and then up to 4 million in about 2 or 3 weeks. So there should be pretty widespread availability of IgG antibody testing across the country on existing Abbott platforms. That is a true serological test, not something from a less reliable source, shall we say. And there's a competitor to that that's also came out in the last couple of days, and I can't remember the name of the company off the top of my head. So presumably they also are going to ramp up very rapidly to widespread IgG testing.
Okay. Oh, go ahead.
And then the second group of people that are going to get tested are first responders who have had no symptoms and no tests. So they are, and the real question there is, could these people come in, get tested now, verify that they in fact are not infected yet, and then they get followed prospectively. And some fraction of those people will end up getting infected. And so they'll have this sort of pre-infection immunological markers. So they're looking at their T cells, B cells, et cetera, to try to see if they can predict or develop a prediction model that would say this person is at very high risk because of something about their immune system. So that's basically what we got going on, Paul.
So one of the things that I think we've always cautioned about, and we heard from Mike Osterholm, for example, last week, was this issue about, okay, you have antibodies there. Does that mean you are immune? And we're hearing some anecdotes, I think, or maybe some true reports out of Asia that people are having either reinfections or maybe they're relapses. And so maybe they didn't have, they may have had an antibody buildup for a while, but it just wasn't strong enough. It needs to be reboosted like we do with so many vaccines as an example. So are we really protected, or are we just going to say people have a license to get out there and move around because they think they're immune, et cetera? What's your opinion about that?
Yeah, I think we don't, as you point out, we really don't know the answer to this. Our research questions that this team is working on could include answering that a little bit, because they'd have a group of people that did test positive. It's still pretty small, and they are going to get repeat testing over a several month period of time. So we may identify a cohort of those folks who do get reinfected.
Now, the next question also is that it sounds like they also have the capability down the line of doing some very sophisticated tests, looking at the various things like T cells and B cells and whatever else, right?
Right. Yeah. So it's, I certainly as an emergency physician know absolutely nothing about this. And this is all about who you know. So it turns out the lead researcher at the Fred Hutch Cancer Research Center is the stepmom for the union president for the Seattle firefighters. So he made the connection for us and suggested to his dad and to his stepmom that maybe first responders could be good candidates for this research. Yeah.
Well, that's great. Well, thank you then so much. I'll keep you there as long as you can, if you don't mind.
Yeah.
But that's kind of a good thing. Peter, Anteb, are you there? You want to just tell, like, in about a 1-minute spiel what you're doing, along the lines of testing a whole city, I think the whole complement of a whole city employees across the whole of 2 cities, I think you're looking at, right?
Yeah, and we would agree with Michael 100% that we have no idea what this is going to look like. Just to start, that we already have 100 patients that we've tested. A large portion of those are just folks who have never been sick. We're just kind of checking out our surveillance methods. And then we have about 30 who have had the disease. What we're finding is that the IgM shows up, the IgG shows up, and then we're seeing now that the IgG completely just falls away completely on these little antibody tests. So again, very difficult to understand if this is going to work or not. What Paul's alluding to, we just submitted our IRB 2 days ago to the state. We're going to do 2 cities, and we're going to test all the employees in 2 cities, about 2,000 people, and to understand whether or not we can pick up asymptomatic, individuals with an IgM or an IgG response, and of course linking it to their symptoms. If there's a positive result, that patient will go and get the RT-PCR performed at one of our local sites. And so we're going to try and confirm whether or not any positive we pick up is truly positive. Now remember, the research protocol is that these cities already have their plan developed. We're just going to be observing their data. And so every city manager, every city is doing it just a little bit a different way, but it'll be interesting to see what we observe over time.
So we had our concerns about that, and that's why we said we'd like to study this, and we are going to try to look for some discrepancies. We're going to look for, we're not absolutely sure about let's say, if you get a positive test, are you immune to? Is it actually reliable? Is it cross-reacting? Because most of the tests are out there actually were developed from SARS and developed from coronas. And then Ken Shepke, are you there by any chance? Can you talk to us about what's happening with the people in Pompano?
Yeah, sure. So Dr. Anteve and I had a chance to speak to the lead biochemist at this one company in Pompano Beach that is producing one of these studies. So we got a little bit of an education from him. Apparently, a lot of the studies that are out there, according to them, keep in mind, this is not verified. So I don't, and they're competitor companies, but this is what they told us, is that a lot of the tests that are out there for these lateral flow immunological assays are using the SARS-1 spike proteins. So according to the International Committee on Taxonomy of Viruses, this is actually not a novel virus. This is actually a SARS-2. It's so closely related to SARS-1, even though the clinical aspects are quite different. The genome is very similar. So there should be some expected cross-reactivity between the spike proteins, which is, there's 2 subunits, S1 and S2. And these are the proteins that are involved in viral binding to the cells, generally the ACE2 receptors. And that's what these tests are looking for, is immunological reaction to the S1 and S2, but they are using the SARS, according to this biochemist, they're using the SARS-1 spike proteins. And there's a lot of mutation in this area. So sensitivity and specificity might not be as high as you'd like if you're looking specifically for SARS-2 or the COVID-19. They, however, have now purified using recombinant DNA a spike 1 and spike 2 protein for the COVID-19. And in addition, they're adding the nucleocapsid protein. So that's a protein that wraps the viral RNA, and you can get an immune response to that as well. And they're sandwiching all 3 of these COVID-19 specific antigens onto their lateral assay. And they're claiming now a much higher sensitivity and specificity. So according to them, I'll just give the test results. You'll take it for what it's worth. Understand it's not verified at all. This is just what they claim. That they used PCR-proven COVID-19 cases from Italy, 100 of them, and that 98 out of 100 had either an IgM or an IgG or a combination hit on their assay using these 3 antigens. And then they used frozen blood that was existing pre-COVID-19 days, so you know they're negative for COVID-19, and they had 0 out of 100 hit, so giving you a 98% sensitivity and 100% specificity. So if that's true, then that bodes well for what we're wanting to do for population seroprevalence testing. But we'll see. So as I said, none of that's verified, and that's just what we've heard.
So 2 things we're left with here. Thanks, Ken. By the way, the people you just heard from are the chair of the Greater Broward Emergency Medical Services Medical Directors Association, Peter Anteve, plus he's our in-house, pediatric specialist. And then, of course, Ken Shepke, who's not only the medical director for West Palm Beach and Palm Beach County, but also the medical director for the state of Florida. And so the 2 messages here, one is we're not so sure that the tests we have are actually accurate in a sense. Maybe, and if the things Ken said are true, that they still haven't been validated, then that gives us more inkling about why we're saying that. And number two is that we don't know if it means you're really immunized or not. So it's going to be interesting. But at the very least, if we have better tests and what Mike is talking about and what Ken is talking about, maybe we can proceed further and get an idea about what's happening in the community. There is something I like about what Peter is doing, even though we have those caveats we just threw in, because we may get some surveillance information. There was a report just came out of Iceland, for example, that they got a very small country. It's, you know, demographically, geographically separate from many of us, and so it's in itself. But the size of the country is like 360,000, so it's like Tulsa, Oklahoma, and it's easily manageable. They've tested already up as of last week. About a week ago, they had 10% of the population tested. What was really fascinating, though, is that one of the people who did turn positive on the PCRs, half of them had no symptoms. And then that goes along with our own CDC reports that at least 25% of people are, as the Brisbane people call it, sleepers out there. So it's going to be an interesting challenge as we go forward. And this whole thing where people will feel that they're still, you know, they're safe and they can go out amongst us without a mask or whatever is something we got to be all aware of. Okay. Anything else we should say about that? Because I got a lot of reports to get from around the world here. So I see that both Pierre and Stefan Polacek from Berlin is here. I think since it's so late, let me start with going on and getting a report. I call it, I wonder what's going on down under, what's gone asunder down under or not, and from Paul Bailey. And let me introduce Paul really. Paul's terrific. I got the opportunity to meet with him as I moved through the southern hemisphere last fall. And he's the medical director, not only for Perth, which is the large city way on the west side of Australia, but he's also medical director for all of Western Australia. And the St. John's Ambulance Service, like we heard in New Zealand, and I did talk to Craig Ellis last night. It's fascinating what's happening in New Zealand, by the way. And but Paul has a weekly. The Eagles there, because of the issue that our time difference says, they run their own meeting once a week, and so Paul's one that's like, it's still only almost midnight there. So he said he'd stay up tonight and give us a report from the New Zealand and Australian Eagles, or as I call them, the Anzies. Okay. Okay. So Paul, go ahead. Welcome to the show, by the way. Okay.
Thank you, Paul, and good morning, everyone. So just to set some context, Western Australia's just over 3 times the size of Texas. We occupy the western third of Australia as you look at it, and we've got just 2.5 million people, of whom about 2 million people are crammed into one city. So it's a big state with a lot of desert. And right now we've got almost no disease. So we've got 157 active cases, just had our 6th death today. So we've had a very, so far successful campaign to isolate our state from the rest of the world. We're locked down internally, we can't travel, and our kids haven't been at school for about a month. So we're looking with some horror at what's happening over in the US and wondering if that's our future. And it's really hard to know if we've dodged bullets or if that lies ahead of us. And I think the history of COVID predictions is such that I'm not going to make any predictions about where we're going. We're having weekly meetings with the medical directors in Australia and New Zealand, and whilst it's not uniform, the situation is fairly similar across the region. And in fact, the medical director of Queensland Ambulance yesterday said that if he actually wanted to catch COVID, he'd have no hope of doing it outside a hospital because there's actually just none around. So we currently have a pandemic with no patients, loads of panic, but no patients. And we're getting a lot of really odd things, not in keeping with the burden of disease here. So I think that's a fair summary of where we're at. And thanks very much, Paul, for the invitation to participate.
Yeah, so from what I heard from you last night and the other Australian folks and New Zealand folks is that your calls are down anywhere between 30 and 40% overall for EMS. And
yeah, correct.
Yeah, and you are basically otherwise your emergency departments. You just said people are sitting around drinking coffee, and
well, they are. And we had one of our big hospitals. We, you know, big by our standards. We got a 700-bed hospital not far from here. Shut 120 beds last week because it was empty.
that was one
Our
of your
EDs,
primary centers. That was one of your
two-thirds. Yeah, we're quiet.
And that's your Gardner, and they're primarily they do all of your stroke stuff and so on. So are people still able to get embolectomies or STEMI caths and things like that?
Yeah, correct. Although, just like you, we think we're seeing less strokes and less STEMIs, and we don't really understand why. We don't understand if the disease has changed or if people are toughing it out at home because they're too scared to go to hospital.
Yeah, and we were talking about, we call that collateral damage that we may find later. And we're going to talk later about people who are found dead at home. There's some other evolving considerations, but yours is probably a different situation. You know, it's interesting in New Zealand, what Craig Ellis was telling me last night, I think they've only had 3 deaths across the whole country. They have a country of, what's it, like 6 million there, I think. And so it's been really fascinating. They're even tighter than you guys. They got on it early, and their prime minister is taking a lot of flack because of the shutdown, and yet nothing's happening. And we're hearing the same thing in Las Vegas, for example. So it's becoming very political to some extent, but you did the right thing, it sounds like, to protect the population. So, all right, anybody?
So far, I think we've been well led.
Yeah. Hey, anybody have any questions for Paul while he's on the phone here with us? And by the way, it's great to see you and great to have you on the line with us. All right.
Thank you.
I think I'll pivot next over then to David Ratliff, because we haven't heard from him for a while over in Manchester, UK. David, are you around and can you talk to us?
Yeah. Can you hear me if I speak now?
Yeah, you look great, and it's good to see you. And I'm glad that you make a good soup, man. It says behind you. All right.
So yeah, just in terms of we cover the northwest of England, and my specific responsibility at the moment is the city of Manchester, where I'm city lead for the ambulance service, but also clinical lead for urgent and emergency care. And currently, we've got around 211 ventilated patients with COVID, and our in-hospital issues, to be honest, sound similar to Western Australia, is that we are empty. We have 50% bed occupancy in some hospitals, which is unheard of. We normally run at 95% bed occupancy in every hospital. We have 10 hospitals in the city. We've got issues with things like syringe drivers, renal replacement, things like that, which we are solving by sharing. But the big concern to me at this point is, even though clinically we're seeing a lot of COVID disease and it's very interesting, and then the pathways are really interesting, and the deterioration over 2 to 3 weeks is very interesting, my biggest concern in terms of safety is what I'd also think would be a problem in Western Australia is, what about the non-COVID disease? And have we escalated into a major incident sort of approach when there isn't actually a major incident? So even though we have large amounts of COVID disease, we still have large amounts of capacity. And I'm worried about a second surge of particularly things like, we're not doing endoscopies for query cancers. There'll be a surge for endoscopies, a surge for radiotherapy later on.
Right.
And what about the social inequalities, all those things? And I don't know how we can defend being on card 36 and doing no sends to patients when we have capacity. So at the moment, I'm trying to produce a safety siren report, which starts to detail the actual versus expected and looks for causality, and also thinks whether we should start ramping back and the recovery cell of a major incident starts sooner, even though we've got a lot of COVID activity, because I think it's plateaued, and I think that we'll be like this for months. So we have a responsibility to the non-COVID patients.
So you got some advantages in the sense that, like the folks in Australia and you with the NHS have, it's not a proprietary interest that the hospitals may have, but I have a feeling that the hospitals here in the United States are losing lots of money, and it's going to have some major impact. But then again, with you, it comes back to probably, I don't know if that's a better use of utilization of resources that you have going on right now. But I think you're right. We're all worried about this so-called collateral damage, which may be the late, the cancers weren't figured out early on, or whatever it may be, or the strokes that didn't get taken care of. So we have the same concerns as well. Overall, though, you're doing well, hoping your family's doing well, etc. So.
Yeah, I think we're doing, actually, family-wise, my wife's a midwife, and so her work's just ticking over normally. The adult children coming home is not a reward, I have to say. But the rest of it, it's actually very interesting. So even though we're working a lot, I still find this is absolutely a fascinating experience to go through.
Yeah. One thing I do want to ask you, I got to pivot off to the other people, but I do want to ask you, since I got you on the line, is that we're going to be talking later about some of our cities are seeing a huge uptick in cardiac arrest out of hospital, whereas some cities are seeing really no change whatsoever. And we're going to try to do a study. I think we'll bring it up later about maybe figure out why that is. We'll look at the observation, then see if we can make some correlations to figure out what's going on. What are you seeing there, or what are you hearing around the country?
So we've got real concerns about this. So the problem is how you measure things and what the lag time is on the final measurements. So our actual cardiac arrests that we're going to haven't changed particularly.
Okay.
But the character of those, the return of spontaneous circulation, and they found dead in beds have changed.
Yes.
So I'm very concerned that we don't know the causation around that. So is the causation a delay in response? Is the causation people who are scared to ring? Is the causation a change in the heroin quality? I don't know.
Yeah.
So we are really looking at that. And anything you do will really help us.
Yeah, and I think if you can hang in there, we're going to have an interesting discussion on that. One major theory is that there's hypercoagulability and there may be more pulmonary thromboembolus that's going on as a theory, a working theory.
Yeah.
That's just to throw that out there. But I think it's in tribute to your neck of the woods. I think it was said at one time that the truth is really pure and never simple. Yeah, and so we'll see that. And we'll see. All right, let me go on to, if that's okay, Dave, I'm going to move on and talk to the other countries. Well, let's go ahead and go to Pierre, if you don't mind. Give us a brief one, Pierre. Anything new happening with you, Pierre Carly, from Paris? Or do we lose
yes, the situation is beauty in Paris. As it was explained in New Zealand, we have the impression that all the other things except COVID had disappeared for several weeks, and now we are in the COVID up to such a plateau. The number of patients admitted in intensive care unit is slightly decreasing. The number of patients admitted in hospital is very high. We have 13,000 patients hospitalized in the Paris area, and we have about 2,500 in intensive care unit, and about 5,000 people, but this is from the COVID. So it's really high level. However, if we consider the EMS, we are now up to the normal level for the season. That means we have less COVID patients and less other emergencies. So the concern you have in New Zealand and other places where the patient have been is an important one. However, in the past 48 hours, we have seen the acute coronary syndrome back, the stroke back, and so on. And it's quite difficult to manage this patient because most of the specialized units have been converted in intensive care unit to treat COVID patients. So at the time being, we are trying to rebuild the pathway that will make the patient have a good survival, even if they are not involved in the COVID disease.
Okay. Well, then let me now, thanks again, as usual, and thanks for the tough job you're doing, because you're a major interface with the government as well, so up in the health system for the whole country. So I'm glad you're there. So it's really terrific. Stefan Polacek, what's happening in Berlin? Anything new since we talked?
To make it shortly, nothing special new. We have the same situation as Australia or England. Numbers are down. I have not more and not less STEMI and stroke, just looking at the numbers, watching also the numbers for suicides at the moment. But the most challenge at the moment is at home homeschooling, and for the people in the hospitals to deny the wishes of the elective surgeries. So that's the main topic for Germany at the moment, or for Berlin.
Okay, great. Thank you so much. So I think now I'd like to swing over and bring up another topic that we have for the morning, and that is the issue of serum harvesting. If we could look at that real quickly. And so I'm trying to remember who was going to maybe do this. Peter, are you going to? I'm trying to think if Jean-Louis is here, because I know he was assigned to do that for the whole country of Belgium, but I don't see him here. So Peter, why don't you tell us a little bit about what's happening, if you don't mind, down in your neck of the woods. Sorry to be so Florida oriented here, but that's I just happen to know about these programs. But there's a good one going on in San Antonio, so we're going to get to that as well. Okay, so go ahead, Peter.
Oh, do you see my screen?
I can see it. Convalescent plasma, COVID. Show me the data. Good startup. Okay.
Okay, good. Yeah. So this is 3 papers. I want to thank Dr. John Cunha for sending them to me, and Ken Shepke for sending them to me last night. But this is just very quick. I'll be fast, but I'll send you the slides afterwards. So there were 2 other studies that looked at this SARS and H1N1 timeframe, and you can see here that for convalescent plasma for SARS, the discharge rate and the case fatality rate were both better for SARS, and then for H1N1, you can see that the case fatality rate was better for the convalescent plasma group. So there was a precedent set before
Hey,
that.
Peter, can I interrupt you? I'm not seeing anything right now. Is anybody else seeing anything, or is everybody else seeing it? I'm just not.
How's that?
There we go. Okay. Thank
Sorry
you.
about that. Yeah, so there's the SARS data up top, and there's the H1N1 data at the bottom. And you can see here, so that we had precedent for that. Now what I want to do is go into the 3 case series that we have. So the first one is 4 patients. You can see that, you know, there were, the first 2 were elderly. They had some other issues. And you can see here that 3 of them at the time of the writing of this paper have been discharged, and 1 still hasn't. Now, if we go through one by one, I think this is important. So this is a 69-year-old, and you can see everywhere here in gray is where they got the plasma. So this person got 200 cc's, 400, and another 300, and they were finally discharged neurologically intact. This person got 1 at 200 mLs discharged. The third person, this is the one who's still in an ICU, got 1, 2, 3, 4, 5, 6, 7, 8 doses of the convalescent plasma, still admitted to the ICU, or it says transferred to an unfenced ICU. I never heard that term before. And then this is a pregnant woman, actually, who unfortunately, you can see here on day 1, they had to actually do a C-section. The baby did not make it, unfortunately, but she did, and she's alive. So that's case series number 1. Then here, JAMA published a paper. This was on in March 27th. 5 patients. You can see they all got the plasma about 10 to 22 days after admission. These were the outcomes and measures they looked at. And I'll quickly go through this here for you real quick. So you can just see here that this is the age. You can see the blood type. They looked at all those things. Coexisting chronic disease is only 1. If you look at here, the disease presentation, look here as far as when they got the transfusion after admission. Again, between 10 and 22 days later. They all were very sick people. They all had many other treatments, including steroids and the antivirals as well. And then the outcomes, you can see here, the temperature in all the patients, 1, 2, 3, 4, and 5 got better. Their SOFA scores, organ failure score got better. PaO2, FiO2 ratio got better. CT value, which looks at the viral load proxy. So a CT value that's up means that the viral load is getting better. This is the number of dilutions it takes. So that's also better. And you can see here that, so again, all 4 values got better on these patients after the transfusion. And then some other data here that 2 patients at the time of the writing were still hospitalized, 3 were discharged home. And then you look at all their lab values, IL-6, CRP, and procalcitonin all went down. Again, I'm going through this quickly here. This is the 3rd case series, 10 severely ill patients. They got 1 dose of 200 cc's of plasma. And they looked at what happened at 3 days for these patients. And the mean time for illness to plasma infusion was 16.5 days. So they were all severe category to start with. The days from the initial plasma therapy from onset, again, they were all after 10 days. And again, you can see the comorbidities here with those. And then the interesting part of this whole study here is what happened to their therapy, their oxygen support before and after therapy. So you could see some went to mechanical ventilation, but you can see here that this is the kind of thing that they followed before and after. They looked at their lab values, CRP, lymphocytes, SAO2, LFTs, and so forth. They looked at that, but then here's the kind of the main outcome, and this was only found in the appendix, is that 7 were improved 3 were discharged, and they state in the paper that all of them were discharged intact, compared to historical controls where they had 3 deaths, 6 stable, and 1 improved. So just to summarize these 3 case series, total of 19 patients. Of the first 4, 3 were discharged intact, of 5, 3, and then 10, 10. So you see 16 of 19 in this convalescent plasma group, 3 of which at the time of the writing were hospitalized. And then of course you had that 1 fetus who ended up dying. So I'll stop there, and that's it.
Yeah, that's good. And this, Peter, just make these slides available to everybody else, because it's a lot of information to throw at us, over the phone line like this. But the bottom line is, you're thinking that even though they're using historical controls, I'm going to say, how do we know these guys just weren't going to get better, or care was improving anyways because they were figuring it out better and they're given all this other stuff? Is there anything that really triggers you to say that there may be something to this?
Well, I mean, I can't say that 100%. Obviously, if you look at the timeline, that's why they kind of looked at the timeline of when these patients got better in relationship to when the plasma was given. So we have these reported data. Then we have several cases here locally of anecdotally people coming off ECMO within a couple of days. So, I mean, I can't state that 100%. This is just kind of what we have so far to lean on.
And there's, as far as we know, there's safety, and from what you're saying. But so just to get us more information about that, a real aggressive program has gone on in San Antonio. If you guys are around, and maybe CJ, you can lead the charge in introductions here. But what I was going to say is that everybody knows that San Antonio has been doing the whole blood program, and that's been an interesting thing. You have to coordinate a lot of efforts, and that's been the Southwest Texas Regional Advisory Committee for Trauma has been instrumental in that, and so has been the blood bank, because the blood bank had to accommodate that so they could give whole blood in the field, etc. So now they're stepping up with respect to this one, and maybe give us an idea of what's happening down there in San Antonio, if you don't mind. CJ, are you there?
Yeah, can you hear me, Paul?
Yep, and there you are. Good to see you,
hey,
man.
Hey, good to see you. So I think you said it very eloquently that San Antonio Fire Department, my office of the medical director, has a really close relationship with our blood center. That relationship over the last 2.5 years has been based mostly on whole blood, but because of that relationship, they are considered an intricate part of our first response system, not just for San Antonio, but for all our 22 counties surrounding us. And I'll say that that doesn't happen with the person that's on this call, Dr. Gomez, who's the medical director at South Texas Blood and Tissue Center. So she called me a few weeks ago and said, we need to get a plasma program, convalescent plasma program up and running, and we need your help since my office knows who all the positives are in San Antonio. So with that directive, we reached out to everyone from the mayor on down to city leadership, and we built a program. And I think I'm going to turn it over because everyone wants to hear kind of the lab perspective, which is really fascinating. And Dr. Gomez, hopefully you're on and can speak to that.
Hi, can you hear me?
Yep, you can.
Great. Okay, so thank you so much for the invitation. So like CJ said, we're working on collecting and distributing COVID-19 convalescent plasma, and this wouldn't have happened without our community partners like STRAC and San Antonio Fire Department. So prospective donors who are recovered from COVID contact us through email or by calling our center, and they go through a very detailed pre-screening process, which includes whether they qualify by their testing, like first off, have they had a positive COVID test, and also their last date of symptoms. We also ask a number of questions regarding high-risk activity and also travel to area with malaria, which would defer them from donating the convalescent plasma. And so once a donor is considered eligible for plasma donation, we perform plasmapheresis on our TRIMA collection platform. That collection takes around an hour, and we can get up to 1,000 mils or 5 200 ml doses, the maximum. It depends on the patient's or the donor's weight and also their height. And a donor can donate every 4 days if their infectious diseases are negative and their total protein is acceptable. So at their first donation, we're also taking a sample for IgG titer levels. This test is a test that was developed at XBiotech in Austin that we now have in our laboratory. And we're going to start running that today using the samples that we've collected so far. And so we're testing at 2 different epitopes at a titer of 80 and also 320. And so if a donor is has high titer for both epitopes, we would continue collecting from that donor. And so far, we've collected and distributed 25 units of convalescent plasma from 4 donors. And the distribution is first come, first serve with our community hospitals. So to order convalescent plasma, a hospital calls our hospital services and places their order with the patient name, the blood type, and what blood types are acceptable. And we just start going down the list once we get plasma collected.
Okay.
So I'll take any questions if anyone has any questions about the program.
Yeah, good. Yeah, any questions out there, CJ, or any comments? I'm not hearing anything at this point in time. So the point is, we wanted to let you know what was going on in a couple places. I bet you some of you all are doing the same thing. I just happen to know about these things to do a biopsy of those programs, and it's fantastic. And I think the relationships that have been developed in both those places, basically largely because of the whole blood programs we had going on before, it really was a nice little pivot into doing something really good here. Hopefully this will work. We're going to see, and so on.
Hey, Paul,
right?
It's Mayor Montes.
Yes, David.
So one of the ways to succeed at this, if you're going to do this, is to make sure that you message the patients that are positive when you call them their results. So for example, when I'm calling a positive, I say, okay, I'm going to send you a text message with your discharge instructions and also about convalescent serum where you can donate. So they get a text message and it gives them the contact information for the blood bank so that in 2 weeks they can engage in the process. So it's important that if you engage your public health or whoever's calling positive tests, that you put that information out to the patient at the time of their notification.
Yeah, and that's actually just to give a plug for you guys, when you started the whole blood program, you had to have a source, and then you had your Brothers in Arms program, which a lot of that ended up being first responders, and those are the people who are exposed, et cetera. So it sounds like you might have a continuity of that here as well, because there are people who may have gotten positive there, right? Is that correct?
Yes,
Yeah,
it is.
correct.
I think it's been really helpful having these partnerships with Dr. Mary Montes and Dr. Winkler. I don't think we would have the donors coming in that we're having without having that strong partnership through the experience we've had with other programs like Whole Blood.
Yeah. So, and again, I think that's again, goes back to some of the quotes that I was trying to throw out before, which is that it's personalities, not principles, that move the age. And so thank you so much for you guys all getting along so well there. All right. So if there's nothing else that I'm hearing from the group, I think I want to move on and take a couple more reports and just salt and pepper it in. I'm going to try to use our busiest cities. One person we haven't heard from for a while because he was just buried under all this is the New York City medical director, a guy by the name of, I think it's Glenn Asada, if I remember correctly, but we haven't heard from him for a while. But Glenn, can you pop in and tell us what's your perspectives? We're anxious to hear about the craziness that you went under and what's happening now.
Hey, everybody. Hope all is well. Hope everyone's taking care of themselves. We actually, as you know, our volume went up about 45% call volume-wise at its peak about 2 weeks ago. We're actually back to our normal volume now in the last week, which is about 4,200. So we went from about 4,200 to 62 to 6,500 calls. In the last 2 days, actually, we've been under by 10% of our call volume. The hospitals are finally catching up. They have fewer ICU admissions. They have more patients that are being discharged out. We had a problem with ventilators as well. We also had some field hospitals that were set up at the Jacob Javits Convention Center, and the U.S. Naval Ship Comfort came to assist. Also, the Arthur Ashe Billie Jean King Tennis Stadium became a field hospital. Initially, they weren't going to take any COVID patients, but that didn't quite make sense. So we actually got them to take more of the stable type patients. So that has worked. We also had the National Ambulance contract come in. Initially started with 30 ambulances, then up to about 200. Initially, they were supposed to be for transfers of patients from the hospital, the 60 or so emergency departments, to the Jacob Javits Center. But it turned out that in addition to that, we actually needed them, especially when our volume was in the 6,200 range, to join the 911 call responses. So they were able to assist us with that as well. Right now, everything seems to be normalizing, except for the fact that our cardiac arrest at one point went up about 8 times as many. We're still about three to 4 times as many cardiac arrests per day. So we went at one point usually to about 25 cardiac arrest calls a day to about almost 200. A couple of weeks ago, New York State implemented essentially the ability for EMS to refuse transport of patients. So if you did not have a temperature greater than 100.2 and your pulse ox was greater than 95%, EMS could advise somebody with COVID symptoms to say you don't need to be transported. Obviously, the patient ultimately could request to go, and we had a problem with our BLS units. 2/3 of our system is BLS, did not have the pulse ox meters, so we did purchase them, and so we actually implemented it 2 days ago in New York City. Don't have thermometers on board, so we're speculating that the patient says they feel febrile. We use that. We're actually looking at it now because we're getting some reports of people who essentially were told they, by the state protocols, they don't need to go, only later to be found in cardiac arrest. So we're taking an immediate QA look at this to see if we need to stop this immediately. So I got my doctor in the QA right now to figure this out. But we're afraid that everyone is of the second wave. Yep.
Glenn, are they going to do autopsy follow-ups on these? That might be really interesting, I think. Like if it is a
the ME's office is very overwhelmed, as you can imagine. I think some of these we're going to have to bring to their attention, because if we essentially told them they didn't need to go and then they were found in cardiac arrest, at the end of the day, it's something we're going to let the ME's office know. Now, interestingly, New York City, the cause of death has changed a bit as well, where even if they don't test the patients at all, on speculation, they're saying they're COVID deaths now. So our numbers have changed a little bit, but not really, if you really look at it. But the number of deaths, in the city, unfortunately, we've had about 118,000 confirmed cases just in the city alone, of which about 7,500 are considered COVID deaths. So we're looking at those numbers as well to see what's going on. We even have outside medical health professionals coming in. Dr. Ye Clement from San Francisco is actually in Queens at one of our hospitals now, assisting us as well. So I've been in contact with him. So we really appreciate all the help from everybody.
Yeah, I know there's someone that's going to get on the line later on. Michael Estreicher wants to come up there as well, so I'm going to make sure you guys are plugged in together. So that's really fascinating. If you could stay on the line for a little bit, it'd be great. One of the things we are going to do is I'm going to try to do that study I sort of alluded to before, in which we'll look at the cardiac arrest numbers in different cities and see if we can get a correlate. I mean, I'm suspecting it's going to be where if your city was inundated like yourself, or in Detroit or down in New Orleans that we've heard so far, and others that may have something to do with it. And that's why some of these other issues, such as the ME medical examiner data, might be really interesting. I'm going to assign a fellow to that, by the way, to sort of do that kind of work, because it's going to take a lot to unfold that. And we'll, if you can work with them, all of you, and I'll tell you more about it later, that would be terrific. Okay. Anything else you can think of?
That's good, Paul. I can stay up for 5 more minutes. I got another call till 12:30. Thank you.
Sure. Anything else you can think of at this point in time? Okay.
No, just good luck to everybody, and please stay safe.
Hey, well, thanks for providing us lessons, and that we got everybody to shut down. And I suspect you're the first person on the planet to say, please keep everybody in, and because I can't imagine what you've gone through. So on a lot of aspects, by the way. All right. So thank you so much, and best wishes to you and Jackie and the kids and so on. And let's move on. Hey, while I have you there, Ed Rock, I see you're on the line as well. So if you don't know who Ed Rock is, he's the AMR, or now GMR, Global Medical Response, nationwide private ambulance service. And they support a lot of communities. And Ed's got somewhere. Ed, where are you now on the number of paramedics that you're responsible for? About 36,000, 37,000, something like that?
It's about 38K.
Yep. And then, hey, how many outside the Eagles jurisdictions? How many more people do you bring to the to our numbers that we oversee?
In terms of population, Paul, I couldn't tell you.
Okay.
So
All right.
46 states, somewhere in there.
Yeah. All right, we'll figure it out someday. But it'd be interesting to see that, because that's obviously additional contributions to what we do here. And by the way, for the purposes of people who are listening on this call later, or in the recorded versions, and you're not familiar with the group, these are most of the people on the line here are the jurisdictional medical directors of the metropolitan large city municipalities. And we've been roughly figuring they're responsible for about 1/3 of the U.S. population in these high risk areas, by the way, as we've just heard. And so just wanted to let you know, and again, this is a reason why we just get together constantly, or talking about these issues and sharing perspectives, enlightenments, and so on, and hopefully some advancements as we go on. So anyways, well, go ahead. Anything report from Ed from your end?
Yeah, just I mean, other than the obvious that everyone is experiencing, I appreciate the discussions on testing. I think from a practical standpoint, our folks nationwide are having a dramatically increasing number of either local physicians, healthcare systems, or laboratories who are approaching the workforce to provide serum testing to clear those individuals of COVID. So we're battling the exactly what Peter and everyone have identified. We're trying to be very cautious and not get folks ramped into the artificiality of testing. I think, I don't remember if it was this group that I brought it up with, but there is a physician in a community that we're in who is testing public safety providers. One of the messages was, if you were IgM positive, IgG negative, you needed to wait 72 hours to have your complete immunity. So, yeah, exactly. So we're aggressively trying to send the message that at this point, from our perspective, the swab is the test methodology that we're using to manage our in work, out of work, and to be very, very cautious of the dramatic underlined increase in the availability of serum testing, and most importantly, what that means. So, Peter, the initial findings of that IgG are so important, I think, to send to the communities. I know, Jim, you've worked with IFF, IFC on the same challenges. So that's a big part of what we're trying to effectively manage with our workforce, because they're obviously concerned, and they're being told that this is the way to determine that they are either immune or disease-free and, quote, safe to go back to your family, unquote.
So that's a big issue. All right. Anything else then, Ed? Because I want to get on. We have a lot more stuff to cover here, and it's already an hour into this. So, but I'm just glad you're here, and thank you so much. And let's stay in touch. And you and I have to talk too about a specific time on Monday that we do.
Correctamundo.
All right. So listen, next, since we're talking about hard-hit cities, Emily Nichols, thank you for being on, because you're so busy. Emily's our director in New Orleans, and tell us what's happening down in the Bayou City there.
Hi, good afternoon. So actually, our story sounds very similar to Glenn's. I think I could just replace the name of the city and you'd hear the same. Our call volume peaked about 3 weeks ago. We were about 25 to 30% above where we usually are. We actually are seeing a return to our usual numbers, which has been very hopeful for us. We do see that most people who don't have COVID are staying at home. We're finding other ways to get to the hospital other than calling 911. And then similarly, we have a very high increase in our cardiac arrest right now. We're about 3 to 4 times where we usually are on that. And so that's really been an added burden just on the crews that we're addressing. And certainly, we're just monitoring that and working with the coroner to figure out as a city how we're going to evaluate that. I think the other big thing that I would just bring up that hasn't already been said is just really the support for our crews. We've put a lot of energy in just making sure that they have the resources. We've been fortunate to have a lot of persons donating food and housing, and we recognize that it's just going to be a burden long-term on the mental well-being of our providers. And so we're kind of trying to shift into that more than anything else at this time. We do have similarly a field hospital that's being utilized. It hadn't filled up as much as we anticipated, which is a good thing. I think the hospitals are seeing a return to their usual numbers, and they're finding a way to keep up a little bit better. And we're cautiously optimistic. You know, it looks like maybe that curve is flattening, but it's a little too early to say for sure. But looks like we're heading in the right direction.
All right, great. Meg, anything you can contribute to? Meg's been doing a great job for you, Emily, because we know you've been busy. So
yes, indeed.
No, if she's there or not.
Thanks for all of this.
Yeah. Okay, good. And then Meg, later Joelle had to get off, but we may want to talk in the future, maybe next time around, about children, any specific aspects, because you are a specialist and they're not only a writer of a children's book, but a person who practices in that arena. So be prepared. Okay.
That sounds great. Thank you.
Yeah. Okay. So let's see. I just want to tell you, Glenn had to get off to get on another call, and he gives his apologies. I think same thing with Joelle. So I'm going to try to get you guys featured next time around, actually, to talk a little bit about pediatrics and so on. And I'm trying to think if there was anybody real quickly I'd like to get on board before they have to head out. One thing, hey, Sandy Schneider, would you be able to get on Tuesday and maybe give the reports at that time so I could get into some other areas here? I don't know if you're there. Sandy Schneider, are you there still?
Yeah, let me go double check.
You have to get off a little while, right?
Yeah, what I need to be off at 11:45. And what time's the call on Tuesday? It's not on my schedule.
Same thing, 10:30 your time.
I can be on 10:30 to 11, or I can do 3 minutes now.
Okay, do 3 minutes now then. So Sandy Schneider, as you know, has been the president of every organization that ever existed, from the American College of Emergency Physicians to SAEM to, I don't know, the chairs of emergency medicine and so on. And now is the associate executive director, as I heard, the AED at the American College of Emergency Physicians. And I heard she did lose one election. I think it was in 4th grade. And that guy was like a star football player. So that's why it was. So
you're using up my 3 minutes, Paul.
I know, that's right. No,
I go way back. So just want to remind you of the resources that ACEP has put out, the field guide, which we're getting a lot of positive feedback from. That is updated almost daily. Look for, in the very near future, we have a joint statement with the American College of Cardiology regarding STEMIs, and Amol Matu has been the person on that, so I'm quite trusting that he's got our best interests at heart. The other thing noted there is financial support. There's a lot of crazy money out there right now. So I would ask you guys to take a look at that for your own personal support, as well as your people in your department. We really are pivoting now to wellness and sustainability along that line. I think I mentioned the last time there are free hotel rooms from Hilton and from Marriott. And a lot of things like food services, cleaning services, pet sitting. It's crazy how many people, as soon as ACEP approaches them, they're willing to give. The one thing I wanted to mention, 2 things rather, real quick. We are putting out a press release regarding the safety of coming to hospitals and the danger of staying at home, very much akin to what you guys were talking about. There's a possibility that this will be a public service announcement with the Surgeon General, but that's not tied up just yet. But there will be something put out by not only us, but hopefully the AMA. And the other one is we are having weekly phone calls with the CDC as one of their partners in all of this. We have been talking about the testing, and their comments to us offline have been very much along the same lines. We're still waiting to see sensitivity, specificity, but if there's something that you guys want ACEP to ask CDC, please let us know. But again, these are our, these and many, many other things on our website are available for you. So I will now figure out how to stop sharing my screen. There we go.
Hey, so thank you so much for the report, and also just being here, being a partner with us. We really appreciate it. And John Kramer from the Feds has been a really great liaison for us as well. So we appreciate it. So I still see there's over like about 50 people on the call. So I think this might be still okay to launch into another area that I think, and we can maybe talk about it more on Tuesday, but I want to start talking about this issue about maybe some of these deaths were due to pulmonary embolus or due to some other issues that may have been related with the hypercoagulability that we're beginning to see at this time. And we started finding out there's some people who are more hypercoagulable and there's some who are hypocoagulable, but for the most part, we're seeing a lot of things like these little micro emboli and infarct, especially in the smaller vasculature. So I wanted to do kind of a quick presentation on that. And so as I'm calling this is plotting against the rotten clotting we've gotten. One of the concerns, why we bring this up, we have had people who have been seen and said, you look okay, go home. And what they did were found dead later, and we're suspicious that this may be part of it. So we may want to have people tested in that point of view. And I thought I'd bring Mike Estreicher on the line to maybe do a quick view about why we're thinking about using TEG and D-dimers and other things to actually become part of a routine if we do see people, even if they're not real sick. So it's just one part of the strategy I just wanted you to be alerted to. And then I'll have John Ju comment on this a little bit because he's looked into this as well. So go ahead, if you don't mind, Mike. Mike is, by the way, works with Randy Katz, who's on shift today, couldn't make it with us in the city of Hollywood, Florida.
Hi, good afternoon or morning or wherever you are. Can everyone see the screen share? Thumbs up if anyone can.
Yes.
Got it? Okay, great. As you had mentioned, there's a decent amount of data supporting this microthrombi formation. It was a really great point you had mentioned about the medical examiner's office, and I actually wanted to talk with the one down here in Florida as well, because autopsy reports are starting to slowly come out of New Orleans. We've read some, and then a few out of China, and they're definitely finding microthrombi, peripheral areas of the lung, and also in multiple organs. There's a few research studies that have come out. I have them available if anyone wants. They're not printed yet or peer-reviewed, but some of the ideas being tossed around are really involve heparin in a multifaceted way, as you can see here on the first slide, where it has involvement with direct invasion to the endothelium, resulting in microthrombi formation. There's also an involvement as far as cell-mediated entry into the cell, and then immunomodulatory aspects you could see here on the top involved in cytokine storms and decreasing the B lymphocyte production, which has to do with early antibody production. So giving heparin is thought to have involvement on multifacets from immunomodulatory aspects and again to thrombi prevention.
Yeah, and so, folks, if you don't mind, Mike, just to jump ahead, and most of this is just to sort of quickly open up the thinking process. We may drill down later on this a little bit more, but the concept is that some people are actually now being sent home after they get some testing done, either on, they're using Lovenox, for example, instead of just using heparin, and maybe some cases they're using aspirin and so on. We don't know the right thing yet. I'm just sort of letting everybody know that this has been an interesting thing and something for us to be thinking about as we approach folks in the future. So for the people who are not sophisticated about this, because not every hospital has one of these, I would like to see if you could tell us a little bit about TEG and why we think that's been a useful thing for us. And for most of us on the phone, we may know this, but the people this is going to go out to, if you can give me literally a 1-minute spiel on this, I'd literally maybe 1 to 2. I'd really appreciate it so people understand what this thing can do and why it's important for some of the discussions that we're having here.
Yeah, I'll meet you halfway, 90 seconds.
Yeah.
So basically, TEG stands for thromboelastography. It gives really a global evaluation of the patient's coagulation profile, in that we've learned from our experience at trauma at Memorial Regional that when a patient comes into the hospital in a multi-injury accident, Even though sometimes they look well, we've seen patients who, from a coagulation profile standpoint, are basically in really bad, fibrinolysis and almost a predictor of how bad they're going to eventually turn. So looking here on this graph here, this is how we get a TEG report basically. So over here is what's called the R value. This is representative of the clotting time. We use the rule of sixes. So about 6 minutes is your threshold. So if you're below 6 minutes, then you're clotting really quickly, and we think you're hypercoagulable, and beyond. And if you're higher, then you're hypo. We also look at the K value, or the alpha, which is just the angle, and that's looking at fibrinogen, and so where you might want to give cryo in the hypocoagulable state. And then also we look at the mean amplitude. That's the area here between the two red curves. And that's what looks at the clot strength, which is primarily platelets. And lastly, over here we see the LY30. That's where you're looking at fibrinolysis and the clot breakdown, basically.
And you see how normal that is. Okay. Can you give us, you got any examples of what?
Yeah, so I'm going to show you two examples of two COVID unit. So I'm going to draw your attention to the red curve on both of these, and that's really where you want to look at. So the first one is a 50-year-old male who was admitted to an IMCU level care. He had an R value of 7.2. Again, that's higher than that 6, and a mean amplitude of 65.4. So in this case, the R value is higher, meaning it's taking a while for him to form his clot. And his MA, his mean amplitude, his platelets aren't so sticky, aren't so activated. So he's actually more in a hypocoagulable pattern. And in this case, this patient was given a recommendation more of a prophylactic dose of Lovenox, whereas this patient down here, you can see the R is really short and that amplitude for the red curve really high, really wide. And he is more hypercoagulable. In this patient, we wanted to give full dose Lovenox and an antiplatelet. So you could see from these two different COVID patients, two different presentations, two different levels of what type of anticoagulation, antiplatelet you want to give. So we see it's really more of an individualized approach as opposed to just a one size fits all.
And Mike, these guys had no other indications at the time that they had some blood diathesis or clotting diathesis.
Right, and they were otherwise healthy people, not on antiplatelets or anticoagulants, and were having mostly respiratory issues when they came into the hospital.
All right, this is fantastic. Great job. And thank you guys for alerting us to this, because it's out there. And we just want people to be aware of it as another one of these strange things that this thing's coming up with. Just like the case I presented to all you the other day on the finger, the guy getting the extreme vasoconstriction, out of nowhere, coming and going. So John Ju, anything you want to say on this? You've been looking into this, and you're our smart infectious disease guy out of Portland. So do you have anything you can comment on that beyond what we just saw?
Yeah, Mike's presentation was outstanding. I would just say two things. Number one, it turns out one of our most esteemed coagulation people was on the MCRIT. His name is Tom Delary. I'll send the reference out. It's well worth listening to. The bottom line is the following. If you actually follow both the TEG as well as the D-dimer, there is good reason for prophylactic anticoagulation with low molecular weight heparin. The second one is if the D-dimer is sky high and the patient is in the ICU, he actually favors anticoagulation with full anticoagulations with low molecular weight heparin. I'm talking about greater than 6 times the normal D-dimer. The other one, sort of interesting enough, that he actually commented on, I might have gotten this wrong, is that there's a difference between regular heparin versus low molecular weight heparin, to the point that the low molecular weight heparin has a greater activity against IL-6 and perhaps even IL-8, which is very important in the COVID-19 process.
That's fascinating then. Okay, well, I just want to make sure, and this all may, again, intertwine with what we're seeing with the cardiac arrest and so on. And the fact that no one had any symptoms, signs of hypercoagulability or hypo it's really fascinating, and it's just great to know that we're finding this here. So thank you so much, John, as usual, for anything you want to comment while I got you online about the other stuff we heard today, or is it all looking good so far?
Yeah, in other words, it's fascinating, Peter's discussion on antibody. So it turns out that the coronavirus is a really weird virus where the spike protein, the glob itself on top of the spike mutates. So if you actually target the spike itself without the stem, the virus could get away from you and mutate, and you could lose protection. So there's a high degree of mutation amongst the RNA virus from COVID-19, and we need to watch that closely.
So is my interpretation of what you just said is that you may not get immunity even though you have some reaction on the antibody, the antibody test. Is that correct? Or
yeah, that's correct. The three-dimensional model, if you actually look at the models on Google, our configuration may change slightly to the point that the antibodies will not be effective against the attachment point as well.
Yeah, okay, that's great. Thank you so much. Hey, and by the way, just so while I was on it, I was going to do another pitch, and I actually did get my copy thanks to Ray Fowler. I don't know if you can see it, of the deadly, I'm trying to figure out how to get this on the screen, but The Deadliest Enemy from Mike Osterholm, and wish we had been talking to him too. Our leaders have been talking to him 2 years ago. So, but thank you so much for keeping us on top of this, John. You've been doing a fabulous job, okay? All right, so then now let's see what else I had on my agenda. One thing I did want to maybe talk about, and I don't know if, and this is this issue about seeing more cardiac arrest and so on, but we might want to maybe delay that one till Tuesday because we're going to get some more data, and I'm going to have someone start to collect the data. And then Lauren Maloney, are you there by any chance? We had you on a couple weeks ago, and I actually, yeah. Well, so we're looking at this thing. You heard that they're seeing a lot more deaths, and we're seeing this hypercoagulability state in some of the autopsies out of New Orleans, for example, and the issue with New York City, yet some cities are actually even down on cardiac arrest, even worldwide. So I just wanted to introduce Lauren to everybody. She may be reaching out to you to find out. We're going to send you the original surveys we've done on that, Lauren, because I talked to you and you're willing to look at doing putting all this together for us. And
absolutely, be my pleasure.
Okay, good. So anyways, just want everybody to know about Lauren Maloney because she's going to be working on that project for us. So she may be calling you or emailing you to get more data or ask you some questions about what's going on. So this is going to be an interesting thing. And I think, is Kevin McVaney or Dan O'Donnell on the line? Because they've seen upticks, right? Are you guys there? And if not, that's okay. I just wanted to see if you could give us some quick insights to what you're seeing and all that.
I can go over it. It's Jim. If you want.
Please do, Jim.
So thank you, everybody, for participating in these surveys. The survey on frequency of cardiac arrest, there were 18 of our jurisdictions that reported increased arrests, 7 that reported they were flat, and 7 reported decreases. You can't map these out very easily, unfortunately, but that's what the data is now. And then our very important survey, thank you to the 44 that filled it out, was about our change in managing resuscitations. 39 of the 44 have implemented changes in managing arrests already, and 5 are planning changes in the next 2 weeks. And it's really difference in management of airway, protection of crews, and then consideration of COVID essentially for each of the arrests. So those have been very important surveys. A couple of other issues I wanted to bring back, Paul, to you.
Yes.
The IFF-IFC have heard kind of from across the country about people who are prolonged test positive. So they have firefighters off with a positive test with symptoms, and then they keep testing them and they keep coming back positive. So I sent it to John Jew, thank you, John, and to Mike Osterholm, and to Rob Lowe, because he had one of these in Columbus. They just don't have any idea what to do with these people. So we're going to have to figure that one out. And then the very important issue that's coming up, that the story from New Jersey about them finding 17 bodies piled up in the nursing home. is not going to be the only one of those that comes out. In my jurisdictions, particularly in Atlanta, which is another one of those second tier outbreak places, the nursing home, senior care facility, whatever you want to call them, are really some hotspot sites. They don't want to be reported in many cases, so they sneak EMS in and out. They don't want to call themselves a facility that Department of Health should be interested in. And I think you guys as medical directors should be aware that there's these facilities trying to hide, and we have to be very aggressive and tell EPI to be aggressive. So thank you.
No, thank you. This is just really actually fascinating about what's happening there. So, yeah, and you know what? I want to go back to what Paul Bailey started this out with, from Paul Bailey from Perth, Australia, when he said this thing is one thing I can predict about this thing. It's unpredictable. So it may very well be that people have a ongoing, you know, just like some people, they have their myocarditis goes on for a while, it doesn't go away, whereas some people completely recover or some people get worse. You know, I mean, I'm just using it as just a rough analogy that I think that's an interesting way. And maybe it also gives the reason why some people have their so-called relapses or their reinfections or whatever it may be. And let me again go back to John on that one. John, what do you think in terms of that concept I just said? Is it reinfection? Is it relapse, or a little bit of both? Or because the antibodies are changed, the antibody resistance is changing, and so on.
That's a great question. I don't think it's relapse. I think it's inability to clear the virus completely, or the virus may have mutated. One of those two phenomena. The puzzling thing is the patient usually is better, so they have actually gotten better, but the virus is actually still there. They're not able to clear the virus. There have been reports of giving serum, like we just discussed, and clearing after giving the serum. Does that make sense as well? So there may be a whole.
Yeah, we lost you there. Sorry, we lost your audio.
Oh, there may be a host versus a virus factor as well. So
okay, got it. All right, let's get that vaccine out there. The one that's going to have to be changed every year anyways. All right, so we'll see how that goes. All right, and then you did talk briefly about changing the protocols. Mike Levy, are you there by any chance from Anchorage, and president of the NAMSP? Are you still on the line with us? I don't know if you are, but.
I am, Paul. It sounds like Jim summarized real well. We can provide the link so people can look at the results themselves of the survey.
Okay, fantastic. I just wanted to also give you an opportunity to be on it. If you don't know, the president-elect of the National Association of EMS Physicians is online with us, Mike Levy from Anchorage, and been really interested in how this was all playing out for a lot of reasons beyond, just the fact that we all want to know. Inquiring minds want to know. So let's see. I do want to. I saw that Hillary Gates is online. If you don't mind, Hillary, you're the editor-in-chief of EMS World, and what's your general? Can you tell us what your readership? You have an idea what it is, at least online, because this recording of this thing is going to go out there, so kind of people might want to know about when they're talking who's it's going out to. If you don't mind, can you talk to us?
Thanks for having me, Paul. We're getting about 300,000 page views a month, which is up about 20% in the last 2 months. Certainly when the pandemic first hit, we had a massive increase in readership. It's leveled off a little bit. I think there's so much information out there that people are feeling inundated or overwhelmed, but very happy to have the Eagles have a presence on our site, and that should be up this very soon.
Well, it's a great idea because I think, this is amazing information that I get on these things. I mean, we still have 40 people, 41 out of the 50 we started with, still on the line here, deep into an hour and a half, 90 minutes. We've gone from Mike's 90 seconds up to the 90 minutes here, and I try to shorten this up, but there's just so much good information, so I look forward to it as well. Has this been good for you as well? What are you thinking from your end?
Oh, I love listening to all you smart folks, and can't wait to get the word out to those who don't know that these are going on, or that you're doing all these surveys and really collecting a lot of good data that can help inform and keep everybody safe.
Yeah. All right. Good. Well, thanks a lot for joining us. Thanks for letting me bug you as well. I'm going to probably be wrapping up soon. We did the rounds a lot last couple times, but I still may want to take anything. Anybody wants to pitch at me today, if that's a nuance or something new going on in their area. One person I'll think, see, is Dustin. Are you still here, Dustin Calhoun? Because we hadn't heard from you in the past. I just want to see what's happening in your neck of the woods.
Yes, sir, Dr. Pepe, thank you. So absolutely still here. Thanks for letting me join as always.
Hey, Dustin, tell them what your jurisdiction is and what you got. Okay.
Absolutely. So I'm the medical director for Cincinnati Fire Department, as well as a number of we have a lot of small departments very close into the city, like many of you do. So Mark Twain once said that if the end of the world came, he wanted to be in Cincinnati because we're about 20 years behind the times. And that apparently applies to Corona as well. So we have seen much less hit here than a lot of places. Ohio is proud to have done some pretty good social distancing, apparently, or just got very lucky. But we have not seen as much as we thought. So our biggest moves here have been much following the rest of the country, doing similar things in our fire department, and then building up our alternative care centers, where a lot of my efforts have been over the past couple of weeks. But we definitely appreciate the Eagles and what we've been getting from that. I unfortunately don't have a great deal to add just because we have not been thrown into the thick of it yet.
No, that's it. One of the reasons why I brought you up, I was looking for Rob Lowe in Columbus because you guys were sort of the center of the opioid crisis. So I just wanted to know what's happening there. Do you think some of these increased deaths are related to people overdosing? And we are actually suspicious, as we've heard from people like Megan Gussick or Stefan Polachek, that there are increased suicides going on. You have any feeling about that or any vibe about what's happening in that area?
Actually, we've actually been seeing a decrease in opioid overdoses recently, and we don't know how much of that is tied to the social distancing or just resources being concentrated away from it. But we're still monitoring that. We have a fairly sophisticated program with that here because of, like you said, being a big center of it. And we have not seen the negative effect that you would expect from the psychological aspects of the epidemic.
Okay, got it. Well, that's interesting then. All right. Hey, anybody else then? Thank you for doing it. And Ben, I guess I should check with you in Milwaukee because we haven't heard from you much in the last, I just haven't called on you. It's my fault. So anything to report from Milwaukee? Because you're kind of I think a hard hit area or likely to be. So.
Yeah, we've definitely been a hard hit area, especially our African-American community has been, of everyone who's reporting, I think we have the highest disparity between the number of African Americans in our community and the number that are dying. So, but we are seeing a little bit of flattening, it looks like, so we're happy there, but not gonna, count our chickens before they hatch. So we have an alternate care facility being set up, maximizing our hospital capacity, working on EMS dynamic triage models as far as if ICUs start getting overwhelmed. So some positive signs, but obviously as soon as we start talking about letting up social distancing, we're kind of reassessing everything. So yeah, thanks, Paul.
Okay, no, it's great to have you on. And I think I do want to just quickly also ask the group as overall, anybody else have anything to add or want to tell us about or any feedback? Hey, how about you, Rob Holman, in Washington, D.C.? You're an ID guy as well, but are you? I think you reported that you're seeing increased cardiac arrest. Is that true as well? I don't know if Rob is on the line. Rob Holman. He may have drifted off because he's, again in a tough spot. Okay, with that, anybody else, please want to pipe in and have any questions or things you want to hear. Please, to make this more effective, I want to make sure people contact me at least 24 hours in advance, if not a little earlier, about what we might do on next Tuesday and then, of course, the following Friday as well. And again, it was fantastic having people like Stefan Polachek and Pierre Carlet and Paul Bailey representing our Down Under Eagles, giving us a report. And I can tell you, I've also talked to the people in, for example, I talked to, Det Velasco again in down in Manila, and sounds like the same kind of stuff that they're having down there. It sounds very New Yorkish, Detroitish, and so on. And they got hit a little hard. They have some issues as well, and so it's just amazing how things are more the same today than they ever have been in terms of everybody getting hit in the same way in some respects. But on the same token, it's a thing. It's totally unpredictable, dynamic, and changing by the minute, as you've heard from these last couple calls. So a lot of things that we have challenges on, but thank you guys for what you're doing. If I don't hear anything else, yes, go ahead. Yes.
I want to make a quick comment on the antibody testing. What we've learned that people are going to be rolling these out. I have here the little pipette that comes with the kit, but actually what comes with the kit doesn't have this inner piece of glass. You can see that there's a piece of glass inside the plastic that allows the blood to just roll up into the tube. Most of these kits come without that glass, and you cannot really suck in the blood appropriately. So the technique is very important. So whatever you use, make sure that you get the right equipment. And oftentimes what comes in the box is not the right equipment. We had to learn that the hard way.
Yeah, Peter, the original ones were maybe giving you 10 milliliters or whatever it is, microliters. I don't know what that, it's certain, not milliliters, microliters, but you got to get like 20 or more. Is that right?
Well, the test varies from 10 microliters to 20 microliters. This new pipette that we purchased has a little black mark here. And when you put it right to the finger sideways, it fills it up without any bubbles. The other way, without the glass, you have to suck it in, and it just does not work. So just word to the wise.
So the point is, if you're going to do this, and we're not suggesting that you necessarily do this because we're not sure what it means or that you're protected anyways, but then the other problem is do it right, okay? And that's the other issue. Correct, Peter? Yeah.
Yes.
All right. All right,
Thanks.
if there's nothing else, I think I've got the witching hour here, and it must be ridiculously late down in Perth. But Paul, thank you for hanging in here. This has been fantastic having everybody there. And so good night to you, and then good afternoon and to everyone else here in the United States and Europe. And we'll see you, next Tuesday.
Thanks, Paul. Appreciate it. Bye, everybody. Stay safe. Thanks, Craig.
Bye, everybody.